I'll mute everyone, and then only speakers can no, unmute themselves.
Sure. So the host has muted everyone, only the panelists can unmute themselves. Let me welcome you to the 94th edition of Thursday Musings, inching toward the century. Informed care, stabilization by a very erudite speaker. We have had the privilege of hearing her once before. So welcome again, ma'am. Over to you, Tufan sir, for the proceedings.
Thank you, Dr. Lim. I welcome everyone to this 94th edition of Thursday Musings. And please go to the next slide, my slide. And we have got two vibrant moderators, Dr. Amrit Pattojoshi, Professor of Psychiatry, and he is a member of Executive Committee of IPS, and Dr. Lim Siddiqui, who is the Treasurer of Indian Psychiatric Society. Saredhan unke paas hai. He is also Professor of Psychiatry. Welcome, both of you. Now I have the pleasure of introducing Dr. Saurabh Tandon, Prayagraj. I had been his guest in Prayagraj, but last time also he had been modest to tell that introduced me as consultant psychiatrist only. But I can add on that he is a very much community-based consultant psychiatrist, available for everyone who needs him. And he had a great lineage of Mr. Purushottam Das Tandon. I think I am right, Saurabh. So with this, I introduce Dr. Saurabh Tandon, and next, Dr. Shashwat Saxena. He is a consultant psychiatrist, PG from King George Medical University, Lucknow, MBBS from Maharashtra University, Nasik. Is a fellow of IPS, fellow of IAPP, fellow of CIP Society, Central Zone, Central Psychiatric Society, Central Zone, fellow of Addiction Psychiatry Society of India, member of Indian Medical Association, 7 articles published in peer-reviewed journals, 1 book chapter published in PG Textbook of Psychiatry, 8 presentations at national regional conferences in psychiatry, chaired 8 sessions in national and international conferences in psychiatry, attended 8 workshops and training programs, conducted 2 internships for university psychology students, total 40 students. Welcome, Dr. Saxena. Welcome, Dr. Tandon. From now onwards, this meeting proceedings is on your shoulders. Please carry on.
A very good evening. Probably the onus of introducing the topic has been, the responsibility has been given to me. Many thanks to the organizers and especially Dr. Lim Siddiqui for bringing me in the basket and giving me this responsibility. Over the years, research has proven that when we see the psychiatric patients suffering from mental health disorders, a lot number of them, they have this ACE, that is adverse childhood experiences. It has been seen that around, if we talk about the youth suffering from the mental health problems, around 94% of them, they have had adverse childhood experiences. For the adults, it was the rate of around 80% of them they had. Those suffering from serious mental illness, up to 98% of them, 50 to 98% of them, they have had history of trauma. And then after it was deliberated, we probably won't be able to help them out totally unless and until we deal with these childhood experiences, which are probably at the base of the problem or are continuing at the baseline, resulting in recurrences. And that led to 2 types of terminologies coming up. The topic today deals with finding out these trauma and victimizations in these people who are suffering from mental health problems and relating them, resolving them today with the current problems and then resolving them. It is based on 5 principles. The
আমার চার্জ হয়ে আছে
would be explaining them in detail, the 5 principles and how on these 5 areas that is very important, how we trauma-informed care can help in actually recognizing these trauma cases or bad experiences, adverse experiences, then going for the recovery of these experiences, then after going for the rehabilitation of the people who are suffering from it, empowering them, and finally using their feedback and policy making. So here I hand over the explanation or introduction. I end it up. I request Dr. Saurabh Tandon to introduce our speaker who will further enlighten us on the topics, trauma-informed care, and how it can actually help in the recovery of our patients, how we can use it. This has become extremely important nowadays because of newer problem as we are gaining more understanding of refugees and LGBTs too. Thank you.
Thank you, Dr. Saxena. I'm going to introduce Dr. Sukanya Ray, who is from Mumbai. She's a clinical psychologist. She's MPhil gold medalist, and she has done her MSc. She's assistant professor in the School of Human Ecology, Tata Institute of Social Sciences, Mumbai. She's a practicing psychotherapist for the past 15 years. Principal investigator of a research project on the psychological impact of COVID-19 in Mumbai. She conceptualized and started the PG diploma in trauma-focused therapy and the certification in trauma-informed care courses, and anchors the teaching and training in the trauma therapy. Contributing editor for the official newsletter for the International Society for Traumatic Stress Studies. Trained in CBT, SFBT, family system therapy, EMDR, internal family system therapy, neurofeedback of applied neurosciences, USA, clinical hypnosis, and several other integrative approaches. She's introducing it in the trauma bus. She has a keen interest in neurobiology of behavior, and her specialized training in trauma therapy gives her an edge in understanding the role of biopsychosocial factors in traumatic stress. I just want to add one more word, that trauma in any form, whether it is in physical, sexual, or emotional, it is going to affect the mental health of the person. And in our day-to-day practice, in our psychiatric practice, other than the basic diseases, we also face a lot of cases who are having trauma. And because of our busy schedule, most of the time we forget to go into the details of that history, which delays the treatment line and the outcome of the result. So I welcome today now Dr. Sukanya Ray for giving us insight about the trauma and their treatment. Thank you.
Thank you, Dr. Saxena and Dr. Tandon for the kind introduction. And thank you to the organizers of Thursday Musings for inviting me once again. This is my 3rd time, and I'm really, really honored that I've had the privilege to talk about the trauma lens since the last 2 years. I think it's a very important topic to be considered in both psychiatric care and psychotherapy. And I really am privileged to be talking on the topic of trauma-informed care, especially stabilization. I'm going to start my slideshow. Have the slides come up? It's visible?
Yes, it is.
Madam, yes, madam.
Thank you. So the topic that I'm going to talk about today is trauma-informed care, especially the concept of stabilization. This is a very exhaustive topic, and because we run the courses at TISS Mumbai, we know that this topic really deserves much more than an hour of a talk in such a platform. But I'm going to try my best to cover some of the salient features, possibly giving the audience a sense of what the process is like of stabilization, rather than talking about the specific techniques, because the techniques can be really, it's exhaustive to list out the techniques. But I'm sure that a sense of the process is what is going to empower us as clinicians to adopt the trauma-informed care approach. So before I begin, just a little disclosure about myself. I'm a clinical psychologist and a trauma therapist in private practice. I'm also the faculty in charge for the courses in trauma therapy at TISS Mumbai, which I'll be sharing a little details about that with the audience towards the end of our talk today. The topic can be triggering, so just a trigger alert for the audience that self-care is advised. If you need to distance yourself from the topic, if you need to get away, if you need to take a moment to just balance yourself, please do that. Please feel free to step out as you may. I'd like to start with this quote from by Roger Sperry, the neuropsychologist Roger Sperry, and it has been quoted by Bessel van der Kolk in his bestseller book, The Body Keeps the Score. Prior to the advent of the brain, there was no color and no sound in the universe. Nor was there any flavor or aroma, and probably little sense or no feeling or emotion. Before brains, the universe was also free of pain and anxiety. So I just brought this quote in to highlight the point that there is probably no life on earth that has not been touched by trauma. Trauma is indeed a transformative power, for better or for worse. And this really calls upon the work of Aaron Antonovsky, which is very, in the 1980s, he coined the term sense of coherence, which really talks about that not every traumatic experience transforms into psychopathology. Traumatic experience can also manifest as resilience, as ways in which the individual finds meaningfulness, comprehensibility, and a sense of being able to cope with what's coming. The sense of coherence is really what separates when trauma stays and when it can become part of our resilience, part of our everyday life. So then I just want to bring everyone's attention to the focus of the trauma lens, the trauma-informed lens. What is this trauma-informed lens? We hear so much about trauma, and we tend to look at trauma as something that happened. Quite honestly, most people who land up in our OPDs and our clinics have had something happen to them, or maybe something that should have happened did not happen. So it's not really that trauma survivors have had something special that happened to them. So the trauma-informed lens is not about what happened or if something happened. Sometimes our history taking is driven by this need to figure out what happened or if something indeed happened. But the trauma-informed lens educates us that trauma is not about what happened or if something happened at all. The trauma-informed lens is more about what happened afterwards. So what does this mean? Let me give you an example. Let's say that a little child, let's call him Rohan, for example, fictitious name, and Rohan has had a bullying experience at school. Maybe he has had it for the last few days. And he walks back home alone, doesn't get to talk to his peers, comes back home and sees his mother busy knitting and not really asking Rohan about how the day was. Rohan goes into his room, starts playing with his toys, picks up a gun and tries to just imagine that he is firing at the people he does not like. And there's no one really sort of interpret for him what's really happening in his mind. And this goes on for, let's say, days, weeks, months, or even years. And this experience stays in his brain. This experience that he could not share with anyone stays in his brain. Vis-a-vis another child, let's call him Rahul, fictitious name again. And Rahul has a similar experience. He walks back from school after being bullied, maybe for the last few days. But this time, he meets his mother at home. His mother gently inquires, "Beta, what happened? Why are you looking a little down? Kya hua?" And Rahul feels that maybe he shouldn't speak about it. He's scared. Maybe the bullies have told him, "Don't tell anyone, or we'll, bash you up more." So he doesn't feel okay to share it with his mother initially. But Mama goes on, tries to melt that resistance, goes on saying that, you can talk to me, you can tell me what's going on, it's all right. And Rahul proceeds to tell his mom, even starts crying. And there is his mom holding him, hugging him, telling him, "Oh, that's terrible. I wish I was there to protect you. Do you want my help? Do you want me to intervene? Do you want me to advise you?" So there is mom trying to regulate that state of confusion and pain of the child. So trauma is not about the fact that the bullying happened. Trauma is about the fact that there was someone to regulate Rahul, but there was no one to regulate Rohan. Trauma stays in our brain in a different way. It's coded in our brain in a different way. I want to bring our attention to this wonderful theory, the polyvagal theory by Stephen Porges, which has completely revolutionized our understanding of the autonomic nervous system. Initially, we have been looking at the autonomic nervous system as just having two branches, the sympathetic and the parasympathetic. But Porges' work shows us that, especially in mammals, there are three innervations which have, which have advanced according to the evolutionary ladder. And he talks about how the vagus nerve has three innervations. And the vagus nerve has a very important function in terms of regulating heart rate, in terms of regulating breathing, in terms of a lot of involuntary functions. Without going into details of this wonderful theory, which Stephen Porges has edited over the years and brought out a nuanced understanding of how our nervous system works, this is something which has really enlightened trauma researchers across the globe and helps us in tracking our clients' nervous system. He talks about these three innervations, and he talks about the special innervation of the vagus nerve, which is the ventral vagal complex. The ventral vagus has a lot of connections between the face and the heart, enabling what is especially seen in human beings as social engagement, the ability to connect with others, the ability to have relationships, the ability to actually enjoy companionship, be curious, be open to explore, and at the same time, feeling safe and grounded in the here and now. But there are more the older innervations of the vagus nerve, including the sympathetic zone and the parasympathetic zone, which is also called the dorsal vagal complex, come into play when the nervous system responds to any sort of danger. Now, the danger can be of two types. Danger can be a sense of that something's out there, or it can be of life threat. When there is a sense of that something's out there and I need to respond, the nervous system kicks into the sympathetic nervous system zone. And this enables fight, flight, and two other kinds of behaviors that enables us to take action. The nervous system in this zone is ready to take action on the danger, on the stimuli that is signaling danger. The dorsal vagal complex is of critical importance because when there is life threat, like when you see a possum or a little mouse that's running away from a rat, and the rat finally, running away from a cat, and the cat finally catches up with the mouse, it freezes because it knows that that's the only way to probably survive or die. So that freeze, that shutdown response is a function of the dorsal vagal complex, which enables the organism to shut down. And at the next available moment, you notice the animal springing into life and fleeing to safety. The nervous system's ability to move through these different zones is what enables survival behaviors. The dorsal vagal zone has its own advantages of numbing out, spacing out, zoning out, dissociating, things that we are aware of, that we do. Sometimes we zone out, we're not here in the moment, we're not in the present moment, we have gone back. In colloquial language also, we say things like, I'm not here right now, or that I just zoned out, I just spaced out. Or we sometimes say something was going on at the back of my head. So we are quite aware of these states. Sometimes we may not notice it, but others do because it's evident in some non-verbal behaviors. So the polyvagal theory really enlightens us about these three vagus zones and how they are important. All three zones are important for our survival. They have different survival responses. So let me walk you through this. The polyvagus, the vagus nerve basically operates on the principle of neuroception, which is that it picks up cues from the environment and decides which innervation is important, the dorsal, the sympathetic, or the ventral, which needs to be activated. So if you look at it from the point of view of three lights, there's a green signal, a yellow signal, and the red signal. Let's imagine that the red signal means the dorsal zone, the yellow signal means the sympathetic zone, and the green signal means the most sophisticated, the most recently evolved part of the vagus complex, which is the social engagement system or the ventral vagal complex. Now we might think that the red zone is a no-go zone. Who wants to be there, right? What work does it have? I'm going to show you some combinations of these three states that result in very well-known and common behaviors. For example, if you had just the green zone and the yellow zone out, this is a mix of feeling safe and also having a little bit of sympathetic activation. This physiological state has another name. It's called play. When we are playing, we feel safe and yet we feel activated. We feel energetic enough to actually engage in both social communication and physical activity and being sort of in that zone of taking action. Let's look at another combination. The combination of the ventral vagal and the red. Now this is a combination of feeling safe and at the same time a little bit of shutdown. Now what physiological state could this resemble? This is the state of surrender. This is the state of intimacy. If we were not able to get into this combination of feeling safe and at the same time being able to bring down the sympathetic activation, we perhaps wouldn't be able to engage in intimate behaviors. Let's look at the third one. Now, this is a combination of the sympathetic zone and a little bit of the red zone. A familiar physiological state for this is the freeze state. The freeze state is defined not as the shutdown state, but a state where we know that there is a lot of energy, but we are also locked in that. So we know that if required, we can actually fly it, but we are also able to lock ourselves for a moment in that. All three psychophysiological states are critically important for survival. Play, intimacy, and also being able to switch from a space of freeze to flight behaviors. So the polyvagal theory really informs us that the nervous system does all of this jumping through the three zones in order for us to survive. The brain really knows the way home, so to say. So if that's the case, what we first need to do is to be able to apply this concept in trauma-informed. But before that, let's take a look at research done on how do we decode trauma. Because trauma, as research has shown, is in the unspeakable. A quote from Judith Herman's book, Trauma and Recovery. Her book starts with this quote saying that the ordinary response to atrocities is to banish them from consciousness. Certain violations of the social compact are too terrible to utter aloud. This is the meaning of the word unspeakable. Whatever is unspeakable, whatever cannot be stored in words, is stored differently in the brain. And that's the work that Bessel van der Kolk has brought to the world, which is this is the picture of speechless terror. This is a picture of how the traumatized brain, or when people are in trauma recall, looks like. As you can see, that in trauma recall, the visual cortex and the right limbic cortex is activated, whereas the left Broca's, the Broca's area or the left speech center shows as deactivated. So this is exactly the picture of speechless terror. There is no speech, but there is recall of everything that concerns emotions and sensations. This is in short how the brain looks like when the past becomes the present. Now, the work of Peter Levine also informs us of two different memory complexes, the explicit memory complex and the implicit memory complex. The explicit memory complex includes things that we can remember and define in words. Declarative memory, information that we store. Also episodic memory, things that happened and when they happened. When was the last time that you were at a friend's reunion, etc. That is also the implicit memory complex, which is all about emotional memories and procedural memories. Now, if you look at the arrows that connect these two systems, you notice that there is a lot that's going on that's being sent up from the implicit to the explicit memory system. But there is very little that the explicit memory has control over on the implicit memory system. So which means that the implicit memory system, which is basically the limbic cortex, is sending up a lot of messages up to the prefrontal cortex. But the prefrontal cortex has very little control over the limbic cortex. Now, what does this mean? This means that trauma memories show up as implicit memories or as symptoms. So trauma memories don't show up as narratives. It's not about what happened to me. It's not about the meaning that I have made out of it. Trauma memories often show up as any or all of these symptoms, ranging from irritability, mood symptoms, loss of interest, numbing, decreased concentration, the works. We've all seen combinations of these in our clinic. So the trauma lens really is a trans-diagnostic lens, and it's enabling us to look at almost any of the disorders via not what happened, but what has stayed, what part of the past is still present. That's the lens that helps us look at the client's present and how can we help the client to be more present in the here and now. Now, this brings us to the whole concept of what are the possible sources of re-traumatization in the prevalent ways in which we are doing history taking, in which we are talking to clients. What could be possible sources of re-traumatization? Dr. Janina Fisher talks about simple questions that we are, we organically come up with, questions like what happened, or things like what did you do then? When this was happening to you, what did you do then, or what did you feel then? These questions are simply allowing the client to narrate out their story without doing the background work of stabilization might actually be re-traumatizing for the client. Because every time the narrative goes on, the brain goes back to trauma recall, and we saw just how the brain behaves every time it's in trauma. So being an empathic listener is what we have been trained all our lives. But then this fifth wave of psychotherapy, the trauma wave, has been informing us about how just being an empathic listener without doing the background work can actually make things go wrong. So focusing on knowing what happened in their lives, wanting to do a thorough case history taking that does not involve resourcing can be a possible source of re-traumatization for our clients. So the trauma-informed approach is rooted in the principle of non-maleficence, or do no harm. As we saw, that catharsis has been looked at as a possible source of re-traumatization if it is done without adequate resourcing. Resourcing is actually more important for the clinician than fact-finding about, what happened, what age were they at. It's critically important for clinicians to first anchor clients to the present, anchor clients to the therapeutic relationship, psychoeducate them about trauma and the impact of it on their brains. And thus, we help them develop skills. We help them, develop the resources that can help them stay anchored to the present. The trauma-informed approach is polyvagal informed, which means that when we are trained in the trauma-informed approach, we are able to track the client's polyvagal zones. We can say, and we can, collaborate with the client to be able to figure out where they are at. And that's one of the things that I want to talk about in today's conversation. Moving on, here I wanted to bring out some differences between what is the trauma-informed and what is the trauma-focused approach. The two are all about preventing re-traumatization, but the two have a very stark difference between them. Both aim at preventing re-traumatization and developing stabilization in the client. Both have taken a strengths-based approach to the client. Both help the client relate more to the present rather than to the past. So we are trying to anchor the client. But what the trauma-informed approach veers away from is actual healing of the trauma. The trauma-informed approach does not work through the trauma, but works around it, meanders around it. The trauma-focused approach enables clinicians to develop skill sets that can actually help them work through the trauma and being able to heal the trauma. So the trauma-informed approach takes the route to not attempt any corrective emotional healing of the attachment trauma or what has stayed behind, but it helps clients to stay in the present, develop more stabilization skills, and be able to respect the experiences that they have had. The trauma-informed approach, therefore, can be a time-limited approach, whereas the trauma-focused approach deserves more time, intensity, more skill sets in the therapist, and that's where the different trauma-focused modalities come in. Moving on to stabilization. The concept of stabilization is not new. It was introduced back in 1889 by Pierre Janet, a contemporary of Freud, who did some amazing sophisticated work in the field of dissociation and multiple personality disorder at that time, hysteria as it was coined at that time. And he really talked about how complex traumatic syndromes needed a phased approach to work with. He was the first clinician to bring out the concept of stabilization. And from stabilization to move, and stabilization was important according to him to be able to contain some of the symptoms of the individual before clinicians could move on to explore traumatic memories and be able to heal those memories and proceed towards personality reintegration and rehabilitation. Cut to 1992, and we have the wonderful work of Judith Herman. And in her book, she talks about the phased approaches, the three-phased approach to trauma work, complex trauma especially, safety, remembrance and mourning, and reconnection. Safety is important, according to Herman, that safety is the space where safety is built in not just the therapeutic relationship, but also in the client's ability to stay more in the present as they walk through the traumatic experience. Herman also defines stabilization as the central dialectic of trauma therapy. What does this mean? Herman acknowledges that there is an innate need to tell the story, and at the same time, there is also this biological way in which the brain can dissociate. So because dissociation is an innate ability of the nervous system to compartmentalize experiences and be able to stay in the present, because of that compartmentalization, there is a constant tug of war between this ability to compartmentalize and to be able to tell the story. The central dialectic shows up in therapy and therefore calls for clinician skills to be able to balance it out. It's really a fine line. Too much of this catharsis, too much of this sharing and witnessing can lead to re-traumatization. And constricting that conversation too much may also make the client feel that they're not being witnessed at all. So stabilization is really the key, the central aspect of trauma work. And what stabilization really includes is joining the client in their distress rather than trying to rescue them out of that state. What does this mean? So we come to another wonderful model that trauma-informed care is based on, but I just want to bring our awareness to another concept, which is, when I say stabilization, many of us might relate stabilization to the concept of how a stabilizer works, that a stabilizer is constantly trying to supply a constant voltage. Stabilization in trauma work does not refer to that concept. It's not about engaging the social engagement system all the time. It's not about supplying a constant autonomic energy to the individual, because we now know that all the three states are important for survival. So stabilization is not about constantly bringing them and helping them stay in their ventral vagal state. Stabilization includes first being able to join as a clinician with the client in their distress rather than jumping in to rescue them out of that state. Principles of stabilization also include what Peter Levine has coined as titration and pendulation. Titration literally means it's taken from the field of chemistry. So it literally means that taking a little part of that experience and stabilizing that little part of the experience bringing up another part of that experience and stabilizing that piece. So instead of taking up the whole traumatic experience, we're taking up small bits of it and trying to stabilize, trying to keep the client in the here and now with that little piece of it. Pendulation, according to Peter Levine, and he's really coined this term, pendulation refers to a natural ability, a natural state that organisms are in, where things can contract and expand. What trauma does is that it often leads to contraction of muscles, and this kind of contraction can also drive the focus away from the fact that the organism can also expand. So pendulation, according to Peter Levine, is a way in which trauma-informed clinicians can help the individual or the organism to slowly come back to that state of expansion. So from that state of contraction to the state of expansion, contraction again, expansion, and thus being able to fully open up what is known as the window of tolerance. So let's take a look at this concept of window of tolerance. The window of tolerance is really a concept that Daniel Siegel came up with in 1999. And as you can see that there's a confluence of different theories based in neuroscience that have really led to this understanding of where the client is, what is the client state. The window of tolerance is a much simpler model, but you can see a lot of semblance of the polyvagal theory in this. And as you see here, the window of tolerance, we all have a window of tolerance, which can narrow down with experience. So when we have, when we experience a lot of traumatic experiences, sometimes the window can shrink. So we are literally able to be in our window of tolerance for much lesser number of stimuli or lesser number of contexts. We are frequently moving out of our window of tolerance because life's not that stable, right? Our context keeps changing. So sometimes the window can narrow down as much, and at other times, by working with practitioners, we might be able to return to a more natural, broadened window of tolerance. When we step outside the window of tolerance, there are two kinds of dysregulation that can happen. The first kind is called hyperarousal, and this has similarities with what we discussed earlier in the polyvagal theory as the sympathetic zone. So notice the symptoms mentioned here: anxiety, anger, being out of control, overwhelmed. There's a sense, there's a lot of energy in the body to initiate some kind of problem solving or some kind of doing behaviors. It's not something that is voluntarily driven. It's just the nervous system that is getting into that state of arousal and action. The other zone that we get into is the hypoarousal zone, which in the polyvagal theory corresponds with the dorsal vagal zone. So the responses that we see in here are these, spacing out, zoning out, numbing, freezing. There's a sense of that there's much less energy in the body. The body wants to shut down. And again, it's not something that the individual chooses voluntarily, but literally sees happening, coming over at that time. So our job as a clinician is to be able to track the nervous system. So what does dysregulation look like? We spoke of how the window can get narrowed because of traumatic experiences. And because of that, there could be far more number of trips outside the window of tolerance. So dysregulation may look like that, a huge number of trips, and it can be both towards the hyperarousal or the hypoarousal. Our goal would be to be able to expand the window so that the individual can stay in the window of tolerance for relatively stable periods of time, but that does not mean that they can stay in this window of tolerance forever, because that's just not how the brain works. The brain needs to go into the zones of sympathetic activation as well as at times to the hypoarousal zones as well. But the ability of the individual to come back on their own is what we call as self-regulation. So how do we track the autonomic state? There are several ways of doing that. One way that we will be discussing today, two ways that we're going to discuss today. One is called the back of the head scale, which has been given by Jim Nye, who is an EMDR therapist. And it involves the instructions that imagine that there's a line that runs from the back of your head all the way to the front. And imagine that this is a 0 and it runs all the way to a 10 here. And the more you are towards the back of your head, the more you are in your past. And the more you are towards the front, the more you feel here in the moment right now. So asking them to sort of point out with their finger or just give it a number enables us to know how present they are in this current. It gives us an idea about where they are. It may not give us an idea about the sympathetic activation. So there is another way of doing this. We can give them a scale which ranges from -5 to +10. +10 really means the sort of a state of a lot of hyperarousal, a lot of energy, max that they have ever felt. And -5 feels like they're drained completely, or they feel really shut down. So one question we first ask them is, how high or low is your energy right now? And we ask them to simply indicate by either pointing out on the scale or just giving us a number of where their energy is at. But that's not enough, because remember we said that it's okay for clients to be towards +10 as well. It's not that if they are at a +10, we'll organically ask them that, okay, we need to come back at 0. We need to first know, why do they need to be at +10? Do they actually need to be at a +10? What activity are they engaged in right now that +10 could be a good match? If it is a good match, do we really need to regulate them? For example, if you're asking someone who's about to step into let's say an Olympic match, if you ask them and they're saying something like, I'm at a +6 right now, would you really want them to come back into their 0 to 5 zone? Maybe they need to be in that zone, to play, to be able to put in their best. So it's important also to understand that whether the task they're into right now actually matches their energy. If it does, well, we may not require at that time to intervene or just regulate the energy level. If it does not, then it makes sense to be able to have a discussion and say that, where do you need to be at? That feels like a good match. So in these several ways, we could constantly track the client's autonomic state. And it's not like you need to ask these questions right at the beginning or the end of the session. You could say this, you could actually track this continuously. There are also other ways of constantly keeping track of nonverbal cues in our client throughout the session, being aware of what the energy is like. Are they fidgeting? Are they sort of zoning out in the session? How is their body communicating to us in that moment about where they are at that point? So putting all of this, especially the concept of polyvagal theory, into therapy is the work of Dr. And she really talks about the 4 R's of trauma-informed stabilization. So as we saw, that it's not enough and nor is it advisable to sort of mechanically bring down activation. If we see that, we need to first recognize the autonomic state and understand and respect the adaptive survival response. Why this autonomic state right now? What purpose is it serving? Is it a good match for what the client is engaged in right now? If not, then we step in to regulate or co-regulate to bring them back into their window of tolerance. Once we do that, the story automatically changes. The story in the brain changes as we move from a sympathetic zone to the ventral zone, or from the dorsal zone to the ventral zone. So we don't really need to do much of the restoring. It's the brain that does it. All we need to do is really the first 3 R's: recognize the autonomic state, respect the adaptive response, and regulate it. The rest, as we say, the brain knows the way. Now, when we look at the window of tolerance and the fact that there are 2 possible zones that people can be in, either they can be in hyperarousal or hyperarousal. When they are in hyperarousal, remember that they have a lot more energy in their autonomic nervous system. So if regulation, what will regulation look like when people are at hyperarousal zone? It would mean that we have to bring down the energy. We'll need to down regulate it. And vis-a-vis, when people are in hypoarousal zone, the intervention needs to be about bringing up the arousal. And that would mean up-regulating. Because the purpose is very different, the kind of techniques that we need to choose are going to be different as well. So there are a host of techniques that can be used for down regulating and up regulating, some of which we might also be doing without actually, sort of knowing whether the client needs down regulation or up regulation in that mode. So down regulation would mean activities which literally kick in the parasympathetic activation, or things that we have been calling as relaxation for a very long time. So relaxation techniques. These could be soothing techniques. These could be distancing techniques that help the individual gain some distance from what's happening right now. Various kinds of containment strategies, modulating the energy in some ways, orienting the energy in different ways, also identifying any overwhelmed parts that are present. As opposed to techniques that we choose for hypoarousal, which are more about bringing up the energy. So it could be about breathing, or it could be about bringing back to awareness or coming back into the environment, noticing things around, or just maybe, experience what's it like to rub your hands together or just move your neck around. So various kinds of experiences and sensations, movements, all of these bring back energy into the nervous system. So this is a critical choice that we need to make when we are trying to do stabilization. Down regulation and up regulation is what we need to clearly know which technique is what kind. Now, I'm going to complicate things a little bit here, because with many clients, we notice that when we ask them to close their eyes and be mindful of what's going on in their head, they immediately say stuff like, I just can't do that. Or you'll notice that they have opened their eyes immediately because they're not able to stay in that experience, that internal experience. Now, with such clients, the inference for a trauma-informed clinician needs to be that there's too much going on inside, and it's difficult for them to stay with all that chaos that's running inside. So with such clients, we need to anchor them outside. We need to use techniques which will help them tune out of their internal experiences. So we use more sensory-based experiences. We use more environment-related cues to be able to stabilize them. This could also be applicable for clients who may have below average imagery, and it might not also work for people who were not able to imagine, let's say, a safe, calm place or a container or any of that. So we might need to use tuning out strategies for such individuals. So there are a host of strategies which can also be classified based on this, whether we are asking people to tune in or whether we are asking people to anchor themselves in the environment. So as we do the work of stabilization, we have noticed that this is the first step in trauma work, and really sort of gives the client the ability to go to the next stage, which is to be able to heal the trauma. So when we are doing stabilization, there are critical indicators that we need to watch out for, so that it gives us a sense of, is this working, and how soon is the client able to gain a sense of that they have skill sets, they're feeling more confident. So what are the indicators of stabilization? One is that we notice that gradually, outside the sessions also, the client is able to soothe themselves. They're able to implement some of the techniques that they learn in the sessions. You might also notice that they are having lesser frequency of those trips outside the window of tolerance. They are also able to engage in therapy. There are more signs of trust, more engagement. Their self-care improves. You notice more self-compassion coming in. They're able to access more adaptive memories and develop more affect tolerance. They're able to stay with both positive as well as negative affect also for relatively long periods of time. So those are some of the principles of trauma-informed care. And I just want everyone to take a minute and just tune into this picture. Just notice. And again, a trigger alert. If this is triggering for you, please do look away. But if you find this inviting, if you find this soothing enough, just notice it. And as you do that, just see where you find your autonomic energy at. On that scale of -5 to +10, or however you feel like naming it right now. As you do that, just notice your breathing, notice your heart, your muscles. Notice the chair that's supporting you or wherever you are seated. How your feet are in contact with the ground. It's bringing your awareness to this moment. Even try to your neck and follow your eyes whatever your eyes find as pleasing. Just allowing your eyes to rest on anything where you are that feels pleasing. Stay there for and as you come back into the present moment, and as you're looking at the screen, these are the two courses that we have designed at TISS. One is the trauma focused therapy, and the other one is certification in trauma informed care. And I thank you for your attention for today's talk, and happy to answer any questions, and would like to thank the organizers once again for inviting me to talk on this topic. Thank you so much.
Thank you, Sukanya. Wonderful presentation. Over to chairpersons for opening comments.
It was an excellent presentation. Enlightening. I learned a lot. It was that much different, that much enlightening. Long back, Professor Rajendra Prasad got a compliment. Examinee is better than examiner. So my knowledge in the field is limited. What Sukanya Reddy said was enlightening, and her information, her knowledge in the field is probably much, much better than me. So thank you for the presentation.
Pleasure, Dr. Saxena. Thank you so much for the kind words.
Saurabh sir. Sir, you are muted, sir.
Thank you, Sukanyaji, for your excellent presentation. You have shown light in a darker tunnel, which is a very dark tunnel for the practitioners, because it is sometimes very difficult to go through the psyche of the patient in the busy OPDs. And most of the time when patient comes with the functional symptoms and conversion disorders, we just say that he's having tension and he's having tension, and that is why he's not coping up with all these things. So thanks for the presentation, and I would like to transfer the mic to Dr. Pattijoshi.
Thank you, sir. So, Kanya, again, an enchanting talk. So we'll take questions. Alim is all ready to ask questions.
Please post your questions in the chat box so that we can take it up.
I'll start with the first question, Alim, if you don't mind.
Yes, you can.
So Kanya is talking about, the stabilization phase. When she was talking about, titration, pendulation. So I was a little confused. Can you give one example and just tell, madam? I think that would be a little clearer to me. Any example?
Yeah, sure. Sure. So often clients, thank you for that question. I didn't want to get into more specifics in the presentation, but I'm happy to answer questions on that. Sometimes clients show up with, maybe something that's coming up as a constriction. So, when you ask them that, what are you experiencing in this moment? The explanation can be something like, I feel like I'm choking. And, the way we kind of ask questions, instead of saying that, where is this, where is this taking you back to? What we can say is that as you're with that choking, that experience of, or the feeling of choking, what's coming up for you? Is there any image? Is there any other sensation that's coming up for you? So they might sort of say that, yeah, there's this sensation of anxiety, that kya hone wala hai kind of coming up. And then you say that, okay, what if we were to take a little slice of that? Like imagine that if we were to cut a slice of this experience, and I'm here with you as we are doing that, and let's just stay with that for a few seconds. Would that be all right? And because you are there, your brain and the client's brain are kind of working together. This is the work of Alan Shore, not my work. Alan Shore has written wonderful articles and books on how the client and the brain and the therapist's brain are co-regulating. It's called right brain psychotherapy. And this co-regulating space enables the client to stay in that experience for just a few seconds. So we don't stay there for even a couple of minutes. We just stay there for a few seconds. And then we bring them back to a zone of safety. Maybe we ask them to, all right, now come back and look around you. Notice something like we did in the last part, notice something pleasant in your surroundings, and then tell me what it's like to be there. And the next time we ask them to go a little beyond that time. So let's say if we had started off with 5 seconds, we'd ask them to hang in there for 10 seconds and then 15 seconds. So we are titrating. As we do that, we are enabling the expansion of their window of tolerance. Does that help? Does that help, Dr. Patel?
I think so. I think he is helped.
Thank you.
Yeah. Sukanya, tell me, suppose almost everyone goes through a trauma in their lives at some point of time. So who are these people who will actually need professional help? Most of us come out of it. So your experiences regarding this, what is the type of personality characteristics, the people that actually need a lot of help?
That's a very difficult question, I would say. And I think that's a question that I wish we all had answers to. I don't think we can fit people into who will sort of have that experience of the trauma staying on. I think all of us do, but it's also about that sense of coherence that we spoke of. And the sense of coherence may come about at several points, not just at the time of trauma, but later on as well. So that's the organicity. So one of the principles that that trauma therapy is based on is the concept of organicity, which means that, which is also the concept that Aaron Antonovsky talks about, the concept of salutogenesis, which talks about that there is an innate shift in the organism towards health rather than disease. So whenever any organism goes through trauma, there is an innate shift towards health. Now, there could be certain other environmental factors which interfere in that shift. So it's really difficult to say who will remain traumatized, but it's easier to probably identify risk factors. So if individuals have different other kinds of trauma, for example, there is what we call as, transgenerational trauma, intergenerational trauma, collective trauma that the community has experienced, or there are other risk factors which are coming from a space of communities going through it, not just the individual. And that might hinder the shift towards health, or the salutogenesis. So trauma therapy really talks about how it's not about the person, but there's this wonderful quote that I would like to talk about, which says that trauma unrecognized in a person looks like personality. So when we are looking at personality as a disorder, it's probably trauma that has gone unrecognized. Years of invalidation by caregivers, or sometimes, other circles as well, other circles meaning peers, etc., can actually sort of lead to this concept of how some people have those innate traits. But the world of trauma therapy does not look at individuals as becoming pathologized, but circumstances which can shape their trauma responses. So it's slightly complicated. The question that you asked probably has a complicated answer to it, and I'm not sure if I've been able to cover all of the points there.
Yeah.
Mhm.
So
I think
questions are,
it
yeah,
is less of
Dr.
resilience. Yeah,
Shashwat wants to ask you.
Yeah.
sure. Yeah.
So, Kanya, you talked about it is personality being affected. That's for sure. Has there been any study that actually validates the use of this therapy in personality disorders and how much it is successful vis-a-vis other therapies? It's one area which is actually very problematic for us, that is personality disorders. And most of us will agree it is borderline personality disorder or impulsivity, which is most problematic for us. So how much means success rate
So
and the vis-a-vis rate?
absolutely. There has been a shift in understanding of what is trauma from a space of looking at trauma as just the outcome of wars and just PTSD, like a single incident trauma, to understanding trauma as also complex PTSD, um, which has been brought about by ICD-11. But what ICD-11 also does is that it does not differentiate between complex PTSD and personality disorders and other disorders, which according to the trauma lens can be viewed as complex trauma. Now, there has been a lot of work with EMDR, with cognitive processing therapy, TFCBT, trauma-focused CBT, and other other modalities of trauma work as well in such conditions, eating disorders, so-called personality disorders, or what we call as complex trauma. Um, the the APA enlists evidence-based approaches. So the APA strongly recommends EMDR for treatment of trauma-related disorders, and also CBT or TFCBT, cognitive processing therapy, narrative exposure therapy, as evidence-based treatments. There are also other forms of therapy which are being, which are under RCT right now, including something called progressive counting, which is showing almost equal efficacy as EMDR. EMDR has also been recommended by the WHO for treating several kinds of trauma-related disorders. There is a group of EMDR therapists who are doing wonderful work with borderline personality disorder in Europe. The work of Dolores Mascara. She works a lot with borderline personalities using the EMDR approach. So there has been, I'm not able to give you the exact success rate, but I'm sure offline I can share the references with you. And it has shown a lot of improvement. They've also come out with a book documenting the protocol for using it with borderline personality disorder. Beyond that, there are also other modalities of trauma that are currently, like I said, are sort of coming up with RCTs, including somatic experiencing, internal family systems therapy, and because the whole field of trauma therapy is something that is in the confluence of neuroscience and body psychotherapy. So we're not looking at treating just the experiences, we're also looking at treating the person. So that sort of opens up the arena a lot more than just looking at the experiences and correcting the experiences. So like I said, that I'm not able to comment on the exact success rate for now, but these therapies have documented evidence of working with these conditions. Thank you for that question, Dr. Saxena.
Yeah, Shehbaz wants to ask, suppose we're treating a female with depression, and she later comes out with sexual abuse in childhood. So how to integrate this into treatment? Also, he wants to focus on memory errors in many cases. So how to clinically address these aspects?
My short answer to that, and it might sound a little controversial, is that we are not lie detectors. We'll probably never know what's a false memory because we don't have any machine to tell us what's really a false memory. Some of my trainers in the field of trauma work have exclusively said that we have no business knowing whether it's a false memory or not, because we want to treat the client as things are showing up in the present moment. So what that essentially means is that as symptoms are coming up, as experiences are being narrated by the client, we include them into the trauma focus of the treatment. And as it goes with the way that trauma therapy works, things do come up even after maybe 50 sessions of trauma work, because we don't do a trauma history taking right in the beginning, in the first session, because we want to build more resources initially before we get to that whole history taking. So things can emerge later on because we are talking about memories which are implicit, memories which I'm not aware that I remember, memories that have been repressed. So they can come up in the course of the treatment rather than at the beginning of the treatment. So as and when they come up, we integrate it. But what we don't do as trauma therapists is definitely to verify whether it really happened or not. We don't do that.
What do you mean by integrated?
We integrate it into the treatment focus. So as we notice that there is an experience of childhood sexual abuse coming in, we will look at that memory. Is that something that the client is willing to work on at that time? And then we will choose a modality that will help us to work through that modality.
Okay, thank you. Amrit.
Another interesting question has come out. Good evening. Thank you for a very nice presentation, madam. My question is, when there are T and many small t, how to proceed?
That's the classic case for complex trauma, that there is not one single event that can be delineated. There are many, many such events, which is almost like a blob. When you look at the memory network, there are many, many such things which are coming alive when we are asking questions. So that's what complex trauma looks like. And there are guidelines on complex trauma. The International Society for the Study of Dissociation, for the study of trauma and dissociation, the International Society for Traumatic Stress Studies have come out with guidelines on how to treat trauma. It also follows the phased approach that I spoke about, which starting from Pierre Janet to Judith Herman talks about. So we follow those protocols, and it's an intensive treatment process, which requires the clinician to be trauma focused, not just trauma informed. So as trauma-informed clinicians, we also need to know when we need to make referrals to a trauma-focused therapist who is trained in some of the modalities with which the memories can be processed. That's the short answer. Question.
Okay, so we are handling the patients individually. There is a question regarding the use of group therapy and integration of this trauma-informed care. So what is your take on this?
Sure. So there are group therapies that are done, and there are therapies like I said, narrative exposure therapy, which is one of the evidence-based therapies according to APA, which is doable both with individuals as well as communities who have undergone collective trauma or organized violence. And then there are other forms of therapy which are also coming up slowly, something called family constellation work, or other group interventions that are possible with clients. A lot of community-based interventions are group-based interventions of trauma. In fact, that's something that we are working on currently at TISS in a project that we have received the UNICEF TGI recognition for the work, and we are working with an organization in Zimbabwe that follows a group intervention approach for community, for healing trauma in communities. So it is quite possible to integrate individual and group work in trauma, but again, it requires a lot of skill set for the therapists who are working.
Yeah, Dr. Shashwat has a question, I think.
Yeah, I have. There are 3 questions. Well, most of us, we are talking about, we are practitioners. Simple catch hands like how to means in which cases, because it talks about hyperarousal too as well as hypoarousal too, and that is almost most of the psychiatric patients, literally almost. One catch point when we should be actually picking up the patient for this therapy, 1 point. Second, actually, is there any technique? Because one of your slides showed that there is mindful breathing as well as mindfulness, which was being used for tuning in and tuning out. Because there are very few therapists, I believe, and I'm listening to you someone is speaking on the behalf of the therapy for the first time. Probably my Lucknow hasn't got any trauma therapist up till, unfortunately, or I don't know. So is there any technique which as clinicians we can suggest, minimal, means that is what we can learn and what we can actually suggest to someone? Because only thing which I found in both the sides of hypo and hyper was mindfulness. So 2 things. One is the catch point for anyone, and the other thing is there any minimal technique which we can actually use somewhere?
Sure.
Because it's a very long time. You talked about 50 sessions too.
Absolutely.
And we don't
and
have
that's
that much.
So, which is why we need to catch that whether it's complex trauma or not. So, if it's complex trauma, it's likely that the client needs more specialized intervention. One of the ways that we can recognize complex trauma is by using quick screening tools. The ACE, as you spoke about, is a quick screening tool. However, the questions are not trauma informed. Because when you're asking questions surrounding that, have you had experiences of neglect or abuse during childhood, you are bringing up those memories. So there are other questionnaires, other screening tools, like there's the trauma antecedents questionnaire, which is a good way of asking about these questions and gaining that information that does this client look like they have complex trauma. If they do, which means that they've had several such big T's and small T's and a lot of developmental trauma, as we say, it might be a good idea to actually refer them out to a trauma-focused therapist because they're going to need that. So which is why I felt that it's necessary to delineate what trauma-informed approaches and what trauma-focused approaches. The second question that you asked, Dr. Saxena, is that are there quick, decisions, right? That's what you.
Anything which is short enough, means not short enough, which we can actually suggest to someone, considering that there are very few therapists, for sure.
So there is no short answer to that, unfortunately. I think the only way to work on that issue is to make our systems trauma informed at least. So the more systems become trauma informed, the more therapists can actually become trauma focused, and there'll be more spaces where we can address it. At least being trauma informed might help to a certain extent, preventing re-traumatization, sort of putting a stop to the trauma being passed on to the next generation. So the challenge really is to make our systems trauma informed. And I'm not just talking about the mental health system. I'm talking about the medical system. I'm talking about the school system. I'm talking about all systems becoming trauma informed. Being able to know this language, that trauma is there in all of us, it's there in our communities, it's there in our history, and it can go unnoticed because it doesn't speak our language always. It shows up as symptoms. So we need to know what are those symptoms that really speak of trauma. But like I said, that if we have an idea about that the individual is showing up with developmental trauma, as we say, pre-verbal trauma, there's been neglect, early neglect, or any sort of abuse experiences that we get a hint of, and we don't need to know details of it. Often when clients start to say that, I would put a stop and say that, would it be okay if I stop you? Because do I really need to know this at this point? Would it be okay if I help you to be in the present moment? And we can get back to this a little while later. So I'll often do that because I know that the more they talk about it, they're going to get re-traumatized. So knowing how to ask these questions is the trauma-informed approach. So if we can train our systems to be a little more trauma-informed, we'll be able to pick out those indicators, use screening tools in the way we are asking questions, in the way we are documenting or doing the history taking. That will enable more, appropriate reference at a time which is absolutely okay for the individual. It also depends on the individual whether they want to work on it at that time. Not everyone is motivated to work on themselves immediately. Many people would take time to sort of think through it and look at the intensity of the approach that it involves. So there are a lot of host of factors, but I think as trauma-informed clinicians, we need to be aware of certain indicators, signs of dissociation. So if we notice that there are moments when we are interacting with them, or their informants are complaining about dissociative experiences, there is something called the dissociative experiences scale, which gives us a measure of how much of pathological dissociation are we noticing in the client. There's also something called the MID, the multidimensional inventory of dissociation, which gives us an idea about how much of pathological dissociation is happening. So these kind of tools enable us to make these judgments that is this looking like a 5-session therapy, or is this going to look like a 50-session or more kind of therapy. So I think using screener tools is really important. The MID is not a screening tool, but the DES is. The DES has a known cutoff point which can help us delineate what kind of dissociative experiences they're having. The more we see clients are not being able to be in the present, the more that decision is strengthened about being able to make a referral. So that's the answer to your first question. The second question you asked was about the mindfulness bit. So the mindfulness bit is really about, mindfulness is really about being in the present moment. But what we try to differentiate is how are we bringing in that present awareness. mindfulness can be about staying in the present moment with their internal experience. So it could be about staying in the present moment with their breathing, or it could also be about staying in the present moment with something in their environment. So let's say that I take up this glass and I touch it to my skin and I notice what it feels like. So this is also mindfulness, because I am just noticing this and nothing else at that point. The kind of mindfulness that we do, whether we are going to tune in, ask the client to stay with the breathing, or we are going to tune out, will depend upon what the profile of the client is. If there is a lot that's coming in their internal experience, the more we ask them to go in, they will dissociate. They'll not be able to stabilize. So it might help to actually focus on something external. So these are some quick.
Last. Sorry.
Sure.
Most of the patients which we see, they are in hyperarousal state. And most of the normal people which we see, then hypoarousal. Means if you just see the across the table, many a times it would be hyperarousal and hypoarousal. In reality, means after a certain time it is so. Because hypoarousals, they are hardly, means general hypoarousals, they won't be coming for. So can there be what is tuning in and tuning out? Because then we can actually suggest something. Because we are talking about hyperarousal, which we generally see. Hyperarousals less often from the other side of the table.
Right. Hyperarousal is something which is more validated possibly because the individual is clearly in distress. They are in anxiety, or they are in fear, or they are overwhelmed. It's something which is much more overt. So naturally people recognize it better than when they're zoned out or when they're dissociating. That's not noticeable. And hyperarousal, simply put, we need to down-regulate. We need to bring down the activation. So it could be anything from slowing down. Sometimes we ask them to take deep breaths, or breathe out for longer. Maybe just take a sip of water, or maybe just sort of doing some somatic work, which could mean that just sort of using the body as a container. So sometimes we guide clients to just hold this part of the arms, the deltoid muscle. We ask them to hold this. This is an exercise from somatic experiencing. And we just ask them to hold the body like this as a container. So what this does is that it helps contain the overwhelm for a little bit. And we can use this as a titrating experience and be able to bring down the activation curve. So there are several such techniques, but it was really not possible to cover several of these techniques in today's short time. Several such techniques allow us to choose what would be exactly appropriate for the client, what would be down regulating, and as per the requirement, what could be a tuning in or a tuning out.
So what to do if a person starts dissociating or regressing? This is a question by Dr. Rashmi, I think.
Right. So the first thing we need to do is to be able to acknowledge that our client is dissociating. And now, as we know, that dissociation is a means of the brain's way of responding to overwhelm. So there is indeed something that the brain is perceiving as overwhelming threat and going into that zone. So the brain really needs to be in the dorsal complex for some time. So we, first of all, need to stop panicking and hurrying in to sort of say that, oh my God, my client is dissociating, let me bring them back immediately. So that's what we mean by joining the client in the distress. And we just notice that they are in that zone and we try to name it for them. Sometimes we utilize techniques to bring them slowly back to the here and now. It could mean beginning to, maybe calling out by their name very gently, asking them, if possible, to move a little bit, making very minor movements. Janina Fisher talks about, how the moving the neck is an orienting response, and it can help bring the individual into the here and now. It could also be about just turning the gaze, or it could just be about making eye contact with the therapist. So there are several of these ways in which we can initiate some kind of regulation for the client to come back to the here and now. So again, like I said, that there are a host of techniques, but it was outside the scope of today's talk to cover all those techniques. But there are several techniques and several references for this based on the different therapies that are there. Different modalities have different kinds of therapies also to address hyper and hyperarousal. And once we get trained in these modalities, or we get trained in trauma-informed care, we become aware of what technique would suit which one.
Okay.
Question. Alim, I'll ask the last question. Okay.
Okay. Over to you.
Madam, if the developmental trauma is not dealt appropriately and properly, do we create another generation of abusers?
Yes.
The abused, do they become abusers if we really don't handle these developmental traumas? So there's a question in the chat box, madam.
Thank you for asking that question. There is this whole concept of how the victimized becomes the victimizer. So the person we are looking at as a perpetrator, the trauma lens also helps us appreciate the fact that this individual is coming from a space where their developmental experiences have led to what is called a trauma response. So how they are meeting with life's demands is with this trauma response. So yes, unchecked will definitely lead to the victimized becoming the victimizer. That's why all the more important.
Hide behind it that I had been abused, it had not been dealt with. So, is it a form of a defense plea in somebody who is abused?
I'm not sure I understood your question about hide behind it. Do you mean that they're falsifying?
No, not, the plea that my trauma had never been addressed properly. So I have become, it might become a defense plea. That's what I'm asking.
Right. So if I understood that correctly, people with whom we see that kind of situation where the victimized become the victimizer often may not have insight into it. So I wouldn't look at it as the individual having that insight that nobody sort of dealt with my trauma, allowed me to heal it, and therefore I have turned into this way of dealing with the world. It would rather come from a person where they don't have insight into that.
Thank you so much.
Amrit, there is a question on dissociative fugue, if you allow.
You have to understand, Sukanya has been speaking non-stop for the last 1 hour 15 minutes, and there will be a lot of questions. So maybe we'll talk about this. You are ready for that, madam? Then it's okay.
Well, like I said, that this is an area which generates endless questions, because it's not just dissociative disorders we are talking about. We are talking about possibly transdiagnostic lens, which enables us look at each disorder and understand what it's really showing up. Dissociative fugue is a kind of pathological dissociation, an extreme form of pathological dissociation. And of course, it can be dealt with in the same way that we deal with trauma-focused therapies. But dissociative fugue or any kind of pathological dissociation is not under the realm of trauma-informed care. It needs trauma-focused approach. So the moment there is pathological dissociation, and that does not mean only dissociative disorders, we need to make appropriate referrals, trauma-focused therapists. The trauma-informed approach is not going to be enough.
Okay, thank you so much. I think we should hand over to chairpersons for concluding remarks.
Yeah.
Saurabh sir, any concluding remarks? You have to unmute yourself.
I would like to say that the good rapport making with patient and the doctor and proper referral to a trained trauma therapist is the key. Because most of the time, when we see a patient with trauma, first and foremost thing is we are not able to diagnose properly that whether this patient is having trauma or he is properly having pathology of depression or bipolar disorder. So it is important to understand whether this condition of the patient has arise because of the trauma or because of the illness, and just by taking good history, we can go up to the conclusion. And then if we are finding a trauma in his past life, we have to send the patient to trauma therapist, because each and everything, whatever madam is telling, is not possible by untrained persons. That's my say. And once again, thanks for the presentation and showing light in this unknown or uninformed area. Thank you.
Thank you, sir.
My sincere thanks for explaining the therapy. though I have still so many questions left. And if you allow me, we'll send you that, because my understanding of the current generation and the previous generation and the trauma and the current level of mental illness suggests that the timelines, they are actually mismatching, probably, to some extent. So maybe we can discuss it. But thank you for introducing to the topic, and that was excellent presentation.
Thank you so much, Dr. Saxena. Happy to take the discussion offline.
Thank you. Tufan sir.
Thank you. At the end of such a long discussion, nice discussion, as expected from Sukanya. She had been a speaker earlier. I consider the whole thing in two backups. As it was rightly pointed out by Dr. Sashwat, there are not a good number of trauma-focused therapists in our country. Even if you decide to refer, whom will refer? And if they are there, they are supposed to be overwhelmed. And the second question I would like to ask about to Sukanya, if she is online. This is about which I have experienced in schools, not I have, in the schools I attend. There are a reasonable group of students who are subjected to consistent bullying, which amounts to chronic trauma. And these children underperform, underachieve, and they are again ridiculed at home. This makes the trauma still more complex. And they are not brought because their parents do not consider this aspect important, nor they do reveal their trauma to them. And some of them can later on become reactive against the people, and if possible, they may become psychopathic. Is it possible?
So like I said that what we are really talking about is the picture of complex trauma, where we are saying that there is not something that can be delineated. It's not something that really stands out, but there are a series of such events that have happened, and the brain is overwhelmed with all that has happened, that it's not here in the present. It's dissociating. It's in the past most of the time. So in that situation, like we have been saying that it's more appropriate to make a referral to a therapist who is adept at not only treating trauma, but also who is adept at working with children and adolescents. So if that answers your question.
Can we consider Salvador Ramos to be one of them, who yesterday shut down 19 children in US?
Absolutely, I was
just for example. Just for example, I am not going to delve into the legal matters of any other country, any other place, but there can be same happening in our place also.
Absolutely. I mean, we just spoke of that, and when I was reading the news about,
I have seen examples where they have become total arrogant and a friend. You can trace back the history. They had the friend who has been the victim. Not anyway, he has been the abuser in bullying. But it is as a welfare state, if you want to be, the school authorities, with the help of the mental health personnel, should take care of that, which is less attended to. This is just my submission, and this fear is too vast. Your job is too vast. Responsibility is too vast. Thank you for your presentation.
Thank you, sir. Absolutely. When I was reading the news today about Texas, it took me back to the same thing that we discussed right now, that the victimized becomes the victimizer. So there is a need to take up that lens as well to understand such perpetrators. There's been a lot of studies actually conducted on conduct disordered children to understand how their brains function. And for them, how more brain-based approaches work with stabilization. So this is the work that has been done by Alan Shore, Stephen Fisher with neurofeedback in such children.
Amrit. Unmute. Amrit, unmute.
तो म्यूट कर देता क्या मेरे को बीच में?
हाँ, कभी-कभी.
Thank you, Sukanya. As always, tough, very, very tough topic. Once the presentation over, we ask them more questions than we had when we started with the presentations, and it can go anywhere, everywhere. So almost every case we talk to, there is a trauma involved in it. If you dig deep, when should you dig? Should you dig? How deep should you dig? Should you dig and leave? Should you cover? Should you cover less? Should you cover more? Lots and lots of questions, and that'll take much more time than a simple presentation, I think. And it's a tough area to work on, and I hope you create much more trauma specialists. That's what we need. Saurabh Boss, thank you so much for chairing it, being the backbone of the whole thing, not getting too much into it. Shashwat has been the force, asking a hell lot of questions which we have been thinking, questions many wanted to put in the chat box, but then he has been the vocal force behind all the questions. And thank you, Shashwat. That's been
My pleasure,
wonderful
boss.
chairing
My
a session. We loved the way you chaired it, and hope we'll call you again.
My pleasure, boss.
Tofan sir, getting the present context of the whole presentation, what is happening in US, what in the last maybe 10 days, 3 such episodes have occurred, and the trauma behind people who have to live with these experiences, who have seen these experiences, the survivors, the victims, the teachers. People now will be worried about sending their children to school. Thankfully, in India, we don't have, even our police do not have, even our army people do not have guns. That's a welcome relief. Thank you, Alim. Thank you to the whole Torrent team. Thank you to our audience. We had more than 160 logins today. Maybe people have been, like Alim was talking, a lot of people are going to Ladakh. So they must be packing their bags, so a little less attendance.
They're already in Ladakh.
Yeah, many are in Ladakh. So it is a very, very intense.
A few of them have become ill by now.
They're not taking time out. So they might not need Sukanya's treatment when they come back.
Yeah.
So thank you again. We will catch up again, Sukanya, if you are free in the next 6 months or 8 months. And if our musings continue. So good night. Thank you, everybody.
Thank you so much.
Thank you, sir. Thank you.
Thank you.
Thank you so much, everyone.
Thank you.
Sir, we can close the meeting now.
Yes.